Hey everyone, Dr. Pat and I would personally like to invite you to join us in our Grow My Baby program. This is week-by-week pregnancy and birth information developed from our experience of helping more than 4,000 women grow and birth their babies. All our links are on our website, growmybaby.com.au. If you're trying to get pregnant, or you are pregnant, and you feel a little bit overwhelmed by all you need to know, then this is the right podcast for you. Welcome to the show. I'm Bridget Maloney.
And I'm obstetrician Dr. Patrick Maloney. And this is The Kick, your expert-led podcast that delivers the essentials of growing a baby. Make sure you head to our website, growmybaby.com.au, to get some awesome free tools like our pregnancy knowledge checker to help you feel like you got this.
Well, welcome everyone. Today's topic, we're going to be talking about growth restriction, or IUGR.
Welcome everybody.
Now, how are you going, Pat?
Very well.
Yes.
We just went out and got a coffee.
We did a perk up. So that's good. We have a coffee addiction, don't we?
Yes. One proper coffee a day if you're pregnant.
Yes.
Everybody else, knock yourself out.
No, I don't think that is the advice. That is not official medical advice, people, right? I did want to start with a review on our iTunes podcast. So this is about that Fragile X premutation carrier. You know, we did that podcast early on, what I wish everybody knew about their pregnancy. Yeah, one of our very, very early podcasts. So it comes from Anna. A friend of mine excitedly recommended this podcast when I first told her that I was starting to think about our own pregnancy journey. I'd been given a trial packet of Elevate from my gynaecologist and a leaflet for reproductive carrier screening, which were both chucked into my bag after my last routine visit, never to be seen in the light of day again. I listened to your podcast, however, and those words carrier test popped up again. I asked my friend if she had had her test done because Pat and Bridget say you really should. That's the bit I love the most. And she said she had and was in the clear. She also only knew such a test existed because of your podcast. Friends and family thought I was going a little bit overboard and were more concerned about my anxiety around ticking all the boxes. But I really wanted to cover all bases, well, before getting pregnant. Cut to 2 weeks later, and on a Monday, my GP phoned me with news that has completely turned my exciting journey upside down. I apparently do have the premutation for Fragile X. I am cleared for CF, cystic fibrosis, and SMA. I was devastated by the news, of course, and I'm still grappling with it, but I honestly believe I would be even more devastated had I not had the test, only to find out once my child was born with physical characteristics or when they weren't making their developmental milestones as they grew, which is the only way I could possibly have known. None of my family knew this genetic condition even existed, and not one has been tested for it. The news has sent ripples through my family too. We are slowly piecing together things that have happened in our family as out of the blue. A great aunt who went through menopause at 34, as actually genetically inherited conditions. My sister and my cousin are now getting tested too, and I'm set to speak with a genetic counsellor to discuss my next steps, and we will start looking into the very real possibility of needing IVF or other treatments to manage this gene. Thank you for your informative, warm and calming podcast. I don't feel like a specimen, but I feel like a hopeful new mum, fingers crossed, trying to find her way through mountains of information, tests and other sources, jammed with scary terms and complicated medical jargon. Thank you for making our journey a little more enjoyable and warmer to wade through. Anna.
Wow.
And a kiss.
Nice. So that's just amazing, isn't it? That's fantastic. So that's somebody who's heard about that through our podcast, gone and had it, and then there are important implications for that for her and for the other women in her family. Yeah, that's so fascinating and such warm feedback. We love it.
Yeah, that's right. Thank you, Anna, for taking the time to tell us about your journey, and good luck on the next steps.
Yeah, there's plenty that can be done, of course, to manage that. And it's just a matter of how far it needs to be taken, depending on more testing.
Yeah, that's right, and depending on her partner. And
so, of course, the ideal time to nut all this out is before you get pregnant.
Yeah. Okay, so now we're going to be covering IUGR, and we have in the last few episodes, we realised how much that term kept cropping up. So it's about time that we look at it, and it also came from a DM that we had from our Instagram. Now, again, if you're not following us, it's at grow_my_baby. I know some people are finding the Kick Pregnancy podcast on Instagram and following that, but we never post in there, so I'm sorry if you've sent us a DM in there. I do check, but come over to Grow My Baby instead. And she went for a non-routine ultrasound, a 4D ultrasound, and her sonographer said the baby's weight, and it started that whole cascade of, oh my gosh, I think my baby's got IUGR. And she was asking about the accuracy of the ultrasound and why. So
Good. Well, let's discuss that today.
Yeah.
So IUGR, of course, is Intrauterine Growth Restriction.
Yeah.
When the baby is too small for the known dates.
Yeah. And what do you mean by too small?
Well, whenever you have an assessment of fetal weight, say, for example, an ultrasound, then they come up with an EFW, estimated fetal weight, and that can be put on a graph where the estimated weight of the baby is graphed against the number of weeks of the pregnancy. And that's ideally a graph that's been made where the normal values are other women in your ethnic background.
Right.
And then an assessment can be made as to where your baby sits on that. So the babies that are in the bottom 10% are of concern to us. That's IUGR, and that's babies that are at higher risk of significant problems in the pregnancy. And then the babies in the top 10% are of concern to us because they might be getting too big to fit out, or they might be that big for a pathological reason. And everyone in between from the 10th centile to the 90th centile is essentially normal.
So you're talking about ultrasound, but how else is fetal weight measured?
Yeah, well, that's why every time you come to see us, we get the tape measure out and measure your tummy. So there's an official way of doing that where we start on the pubic bone and measure up over the top of the tummy. And you should be, as the examiner, you shouldn't be looking at the numbers on the tape measure because that kind of gives the game away, and you might be more likely to stretch the tape to give you the figure that you're expecting. Yeah. Whereas you should be just measuring and then turning the tape over and looking at what the number is.
Oh, wow. Okay. There's a little trick. I know that we've got other professionals listening to this podcast, so there you go.
Yeah, so I think that's a more honest way of doing it, because otherwise you might think, well, this lady's 25 weeks, it'll probably be 25, and you just sort of stretch the tape till it gets to 25.
Is that commonly taught, or is that just your little...
No. I was taught that once, I'm sure.
Okay.
So when you make the measurement, just by a happy coincidence, it should measure 1 centimetre per week of pregnancy after 20 weeks.
After 20.
Yeah.
So they start doing that.
Yeah, so by the time you get to 20 weeks, the pregnancy should be up to the belly button.
And I know that's called fundal height, isn't it?
Fundal height, yeah. So, and then after that, we should get about 1 centimetre per week of fundal height. So a 30-week pregnancy should measure 30 centimetres from the pubic bone to the top of the fundus, which is the top of the part of the uterus you can feel.
And are there any times where that measurement just doesn't work?
Yeah, there's lots where it doesn't work, and that's where ultrasound really comes in. So there's a few scenarios where we wouldn't trust it at all. For example, twins and triplets, no good at all. If the baby's transverse, so neither the head nor the breech is in the pelvis, but the baby's literally sideways, then often the fundal height will be really small, but it might still be normal.
Yes.
Yep. And things that just make measurement difficult, like a very overweight woman, where we're measuring her tummy more than the baby.
And I think in our placenta episode we talked about the position and anterior placenta.
You're listening to The Kick with Dr. Pat and Bridget.
How many times have you Googled something about your pregnancy?
When I was pregnant all the time, Dr. Pat.
Yeah, we get it. You may be confused or overwhelmed. It's normal to want information, but where's the reliable stuff from experts?
Yeah. Now, if you like our podcast, Dr. Pat and I have developed an online program to help guide you through whatever stage of pregnancy you're at.
It's taken us literally 2 years to put it together. 2
long, hard years, wasn't it?
But, it is a game changer in how pregnancy information is given.
Now, how it works is you get to sign up at whatever stage of pregnancy you're at. So you could be pre-pregnant, in your very early stages of pregnancy, late pregnancy, preparing for birth, or maybe you've just brought your baby home. And you get lots of information around that. And then you also get to join our closed Facebook group.
We've called in all our contacts too. So we've got a dietitian, anaesthetist, physiotherapist.
Sonographer.
Yeah, who else? Paediatric nurse, obstetrician, mother of 4.
Oh, just all the people you need to hear from.
So if that's you, come and join us at www.growmybaby.com.au.
Does that matter?
No, the placental position, the placenta is going to take up some of the insides no matter where it is. Yeah, so it's not so relevant, the placental position, but multiple pregnancy, definitely.
Yeah.
Obesity, definitely. And even women who are very, very tall or very short, I think you have to have a little higher index of suspicion about your measurements. And then basically, if that measurement is off compared to where you expect to be measuring, then you've got to get out the ultrasound.
Okay, and so is a person sent to a specific ultrasound place, or does your obstetrician do that, or what happens?
Depends. Sometimes, like for example, in my consulting room, I've got my own ultrasound machine, and over the years I've become much better at it, to the point where I'll often be very confident to do growth scans myself, particularly in the third trimester. But other people may be less so. They might refer all of their scans to an outside ultrasound provider. But whoever does it, there's a protocol for how to accurately measure the baby. And there are some pregnancies, even if the woman's only middle-sized and there's no other reason why you would just distrust the tape measure system, there are some situations where you might get growth scans anyway. And they're related to conditions where a small baby can hide in plain sight.
Yeah.
So that, for example, a woman who had normal fundal height measurements right throughout her first pregnancy, and the baby came out and it was 2.1 kilos.
Yeah, right.
And we missed it. Right?
How could you miss that?
Well, you can. So they can hide in plain sight. They can look bigger. So if you've got a woman who's very slim, then even a small baby will look big on her tummy. And you can be full. And so if a woman has shown in the past that her pregnancies don't tend to measure up with a tape measure, then don't worry, do it off ultrasound. Yeah.
And on ultrasound, you're doing things like measuring the head size and the belly circumference.
Yeah, so the baseline measurements are the head diameter, the head circumference, the belly circumference, and the femur length.
Right.
And those four figures go into a formula and predict an estimated fetal weight overall.
Yeah. And are you looking at anything else on ultrasound?
Well, there are lots of other things we look for. There are signs of what we call fetal well-being. So, for example, if we're looking in the third trimester, we don't only want to know how big the baby is, but what sort of condition the baby's in as well. So we might look at how much water's around the baby, which gives us a good idea of fetal urine output.
I love this because you say a healthy baby does lots of wee.
Yeah, of course. Yeah. So, imagine if we were, hit by a train and you and I were hit by a train, we were in the intensive care. One of the things that they would be doing would be there'd be a catheter in our bladder measuring our urine output, and that would indicate lots of stuff about how we were going.
I like how you said we were both hit by the train. You couldn't decide whether it was going to be me or you then, could you? No,
if we have to go, that's the way.
We're going together,
So the intensive care doctors would be measuring our urine output, and that would tell them tons about how well our kidneys were working, and that would tell them how well our heart was pumping and all sorts of clever things. And so the amount of water around the baby is like that. If there's lots in the normal range, then we know the baby is going well.
Yeah.
You can also measure flow down the cord. It's called Doppler, and flow within various arteries within the baby. Yeah. So in particular, one artery up in the baby's brain that tells us a lot about what the baby is doing. So, for example, if the baby's getting very growth restricted, it might start sending more blood up to the brain to preferentially give blood to the brain. Right. And we can measure that.
Yeah.
So you can tell not only what the baby's doing right now, but how things are trending.
And I'm cheating a little bit because I've just reviewed that video that you did for our program on growth scanning and third trimester scanning, where Pat's got this video that he's narrated to show you exactly what's happening within that ultrasound. Yeah,
talk people through it because it's not just about getting a pretty picture, and it's not just about making sure the baby's the right size. There's tons they can tell about fetal condition now, not just the growth.
One thing that I wanted to ask, and it's often on the interwebs, is are they accurate?
Yeah, they are. Let's look at third trimester scanning, for example. There might be, for example, the report will say we think the baby is 3.2 kilos plus or minus 10%. You're thinking, well, which is it? Is it minus 10%? That's minus 320 grams off that figure plus 320 grams on the other side. That might be the error term. Well, that sounds an awful lot. And it's one of the reasons why we've got to look at other things like the overall condition of the baby. But one thing that it's better at than a one-off, which might have an error, is serial measurements.
yeah.
So if we get serial measurements one after the other, about 2 weeks apart, and in particular if the same person,
Yes.
the same technician, doctor, ultrasound guy, whatever, does the measurements, then you've got the same person using the same technique, putting the little measurement arrows at the exact same position on the baby's head. And that's a much more accurate way to do it, to look at trends.
So that woman who DM'd us, she was concerned that the baby wasn't where she expected it to be at that time. You would advise her to go back and have another ultrasound?
Yeah, so we wouldn't get terribly troubled about a single measurement.
One-off measurement, yeah.
In particular, if that one-off measurement was, if everything else was normal.
Yeah.
So yes, baby looked like they were small-ish, but the water level was fine, the cord Doppler was fine, the baby's middle cerebral artery in the brain Doppler was fine. We go, well, hang on a minute, this looks like a healthy baby. The next thing you do is turn around and have a look at mum and dad. How big are they?
Yeah. Because you could be potentially in the 10th centile because you're little people yourselves.
Yes, so there are some well babies in the 10th centile.
Yeah, right.
Absolutely, in the less than 10th centile.
Yeah.
And one of the ways to work out whether that's physiological or pathological is to look at the other things on the scan and have a look at mum and dad.
Mum and dad, yeah.
So it's a picture that you have to put together. And by far the best thing to do is to do serial scanning. For example, if a baby's on the 9th centile on one scan, you do it again 2 weeks later, 9th centile again.
Yes.
2 weeks later, 9th centile again. Fetal movements are normal. Lichal volume of the water around the baby is normal. Cord Doppler's normal. That's a happy baby on the 9th centile, most likely.
Yeah.
2 weeks later, you do another scan and it's now the 3rd centile and there's not enough water and the Dopplers are abnormal. Well, that's something's wrong.
Yeah.
Yeah.
Yeah. And, we all talk about our dates and trying to compare that to where that baby is, but are the dates ever wrong? Do you ever get to a point in a pregnancy and go, okay, well, let's go back to...
Yeah, well, the dates can be wrong, and it's a potential explanation if the growth seems wildly out, in particular at the start. So, at the start of a pregnancy, all of the little fetuses are the same size, so everyone's 10-week fetus should be pretty much exactly the same size.
Yeah.
Whether you're an African or an Eskimo or anybody. And genetic and racial background features come in later.
Right.
In terms of size. So if you had a really tall couple and a really short couple, their 10-week babies will be the same size. But their term babies won't be.
Yes.
Yeah. So if it's really out in the first trimester, your dates may well be wrong.
Yeah.
And it's one of the very handy reasons if people have got a growth scan, we can go off the growth date.
Yeah. When can you get your most accurate dating scan?
It's in the first trimester before any of those genetic differences have kicked in.
Anything before 10 weeks will be a better predictor of dates.
Yeah, so if someone thinks that they're 12 weeks pregnant and they have their first scan and it says that they're 8 weeks pregnant, they're 8 weeks pregnant.
Yeah.
Yeah.
Okay.
They've missed a cycle or the date is wrong.
Yeah.
Yeah.
And what about, I know, we just expect everything to be lineal growth in a baby, but do babies in utero ever go through growth spurts?
Yeah, it's possible.
Is that a silly question?
No, it's not a silly question. They do go through growth spurts, I guess, even in the natural ebb and flow of growth. But the babies that we're really interested in are small already.
Yeah.
And we're not going to go around looking for benign explanations for them being that small. Yeah. So it would be a mistake to say, growth probably just get better next week.
Yeah.
Especially if there are other things that seem abnormal on the ultrasound.
Yeah.
So, on the contrary, we have to identify those babies accurately and confidently and make a plan for their surveillance and which may well involve early delivery. So, I always talk to my junior doctors about this. You can look at that baby and say, is this baby better off out than in? And if you think you're heading towards the day when it's better off out, then you have to prepare for that.
Yeah.
And do things like give antenatal steroids, so an injection of cortisone to the mum so that the baby comes out with better lungs.
Yes.
Take mum and dad on a tour of the nursery, introduce mum and dad to the paediatricians. Talk about what it's like to have a 32-week baby. How big are they? What colour are they? What will they be able to do on their own and what will they not be able to do on their own? So forth.
And listen to our prematurity podcast.
Very wise.
When your baby comes too early. So that's what the management might be. But can we go back a step and say, what is the problem with having a baby that has IUGR? We haven't really talked about that yet.
Like what's causing it? What's behind it?
Sure, let's do that first, yeah.
So there's lots of conditions that contribute to IUGR, and sometimes they're things that we know that the woman's got or experiencing, and sometimes it's things we only find out about because we see the IUGR and then go and look for conditions that might have caused it. But they're common things: gestational diabetes, preeclampsia, smoking, drug and alcohol, and we've got a bit of a checklist that we go through to see whether these are things that we can manage. Yeah. And sometimes they're things that we can manage now, and other times there's stuff that we're a bit stuck with, and then we need to just put a management plan in place. Occasionally, the explanation is a major fetal problem. For example, if you go along for your 20-week ultrasound, your middle trimester ultrasound, and the baby is already way too small, that's bad. That's probably a syndromic baby. Yeah. So
something like Down syndrome.
Yeah, exactly. So the more benign causes of growth restriction, like familial small babies or even smoking, so it tends to kick in the third trimester. Yeah. Something's much more wrong if your baby is way too small at 20 weeks. Yeah. And that would be a typical finding of Down syndrome.
Oh, yeah. Yeah. And those women that have perhaps got those lifestyle issues, smoking or I even read something about low fruit and veg intake. Diet has something to do with it too.
Yeah, so there are lots of things that I would consider perhaps second tier. Yeah. There's all sorts of data on this. Obviously, people have been probably interested in this forever. How can I best nourish my baby? And there's some less impressive data on all sorts of different things that might contribute, but not nearly as powerfully as something like smoking.
Yeah. Now I'm going to rephrase my question. What is the problem with having a baby with low birth weight?
Right. Well, if you've got one of the babies that has a lowish birth weight because that's just them. Yeah. Then they're nothing much, really. That baby might be born small but vigorous. Yep. The problem with being in the bottom centile is that a good number of those babies are small because there's something wrong. Yeah. They're not small for no reason. And that's why we're so interested in those babies, because whatever the something is that might be wrong might get worse. And if we don't get the baby out in time, the baby might be born in very bad condition or stillborn. Right. So it's a continuum that we have to intervene before it gets that bad. Yeah. So babies that are born very, very small will typically have problems with feeding. Might need a nasogastric tube down and feeding via formula or breast milk via the tube because they're not strong enough or vigorous enough to suck on the breast. They might have respiratory problems. They might have problems maintaining their body temperature and all sorts of other things that might mean they need care in the neonatal nursery for a week, a month, a year.
Yeah. So apart from, like we mentioned about the lifestyle factors and the second tier stuff, there is a lot of guilt for women, if they feel like somehow they've done something to make their baby have IUGR. Yeah. Do you see that?
I see the guilt, all the time. I must say that there aren't many cases where this is down to a maternal decision. Yeah. Smoking, drug and alcohol. Yeah. Yes, but the vast majority of cases in our community are not those things. And, we're fortunate enough to live in a part of the world where maternal nutrition is not the problem. It's things entirely beyond the woman's control. Preeclampsia, gestational diabetes, and syndromic babies. And whilst there's no legitimate place for guilt in that situation, it's a natural human response to things. Well, what did I do? I haven't tried hard enough. I haven't done the right thing. Yeah.
And I know that we do live in a very privileged health society, but I did want to mention that for our Indigenous people, IUGR is a common problem, isn't it?
And that's multifactorial. Yes, there might be, for example, poor levels of nutrition and high levels of smoking, but there's definitely less antenatal care. Yeah. So if you're a traditional living Aboriginal person living in an Aboriginal community in the middle of Australia, you are getting less antenatal care than a patient who lives down the street from my private consulting rooms in Ballarat.
Yeah.
And we can do our best, but there's no doubt that someone, for example, in that group who has an IUGR baby, it's less likely to be detected, it's less likely to be managed, and it's less likely to be managed successfully, which is reflected in the nearly doubling of the stillbirth rates.
Yeah, wow. So can we talk about, because we do get this question quite a lot, what would be your gold standard of care in managing somebody to detect and treat IUGR?
In terms of
in terms of your private care, what do you like doing?
Well, I'm not sure if it's gold standard, but I can tell you.
Gold standard, Pat, of course it is.
I can tell you what I like doing. I think that we should be doing a frontal height at every visit.
Every visit. So we'll go back and just say that from 20 weeks, how many times is somebody coming to see you?
Well, 4 weekly from
20 weeks.
20, 24 and 28.
Yeah.
2 weekly at 28, 30, 32, 34, 36.
Yeah.
And weekly from 36.
Yeah.
So what are the big ticket things that cause growth restriction? Hypertension, preeclampsia, so you take blood pressure every time. And diabetes, so we test for diabetes and we manage it appropriately. We want to detect that growth restriction. Well, how are we going to do it? Well, we can't do it from across the room, so we're going to, laying on of hands, we're going to put hands on dummy, feel it every time.
Yeah.
First thing I tell my students is stand back at the end of the bed and have a look at the woman's tummy. Says, does she look like someone who's 34 weeks? It's amazing how sometimes people will get missed.
Yeah.
And the growth restricted baby's hiding in plain sight. And if you already knew, like for example, if a woman was in a room and you didn't tell the examiner what her gestation was and they just had to go in and work it out from the end of the bed, they might do a better job than somebody who already knew that woman was 32 weeks.
Yeah, right.
And therefore interpret all of their findings to expect them to equal 32 weeks.
Yeah.
Does that make sense?
Yeah, so you're saying don't let your bias come in.
Don't let the bias come in, that's right. So measure the fundal height as dispassionately as you can.
Yeah, turning the tape over.
Turn the tape over and just do your best to say, do you look about right? Yeah. And then improving people's access to ultrasound.
Yeah.
Yeah.
So you mean that they should be going to ultrasound if they're under any sort of suspicion of IUGR?
Yeah, absolutely. Yeah. So if you are a private obstetrician lucky enough to have your own ultrasound machine, get out and make some baseline measurements and watch that baby closely. If you're a referrer for scans, then go ahead and refer. Do it with confidence. You'll find that you're right.
Yeah.
If you think the baby's growth restricted, it probably is.
And a non-sort of medical practitioner listening to this, which is most people, this is something that perhaps could advocate for, like
Absolutely.
to make sure that these are the milestones in their pregnancies that they're experiencing.
Yep.
And if they feel that they're not, then just ask.
Yeah, you must be your own best advocate. And one of the problems with that is that the whole world's an obstetrician, and when you're pregnant, about half the people tell you you're too big and half the people tell you you're too small.
Yeah.
And they're probably both wrong. You're probably fine. But if you've had a baby before and you think you're miles smaller this time than you were at the appropriate, you're probably right.
Yeah.
And that's not something that happens every day having a baby, and you're probably precisely correct.
Yes.
So absolutely bring it up. I don't seem to be growing. I'm fitting into the same pants now as I did a month ago.
Yeah.
You should have grown out of them.
Yes.
Yeah. So those sort of things people do notice. And we're good at managing growth restriction when we know about it, but we miss some altogether.
Yeah. And this is where the woman's there counting her fetal movements and managing, measuring her fetal movements. That's one thing that she could be doing.
Yes, of course, but when the movements go off, that's a late finding.
Yes.
Okay, we want to pick up growth restriction well before the baby gets too sick to move.
Yeah.
And that's by monitoring growth. And then once we know about it, we're very good at that.
Yeah.
Yeah, make a plan, give the steroids, maybe transfer care from mid-level hospital to the high-level hospital, depending on the availability of paediatric care, neonatal nursery, neonatal intensive care unit, and picking the right day when the baby's the perfect balance between fetal maturity versus not too late.
I think I've missed this question. A baby that is growth restricted, do you then go on to induce? Obviously, you go on to induce if you feel that baby's better out than in.
Yep.
Can that baby go through a vaginal birth?
Well, it depends on a number of things. The gestation, when the growth restriction came on.
Yeah. What's
wrong and how severe.
Yeah.
So if we've got a baby near term that we've determined is maybe the 5th centile, the bottom 5%, and the water level's a bit down and the cord Dopplers are perhaps reassuring for the moment, but we've decided overall that it's time to get on with it, then sure, we would try and do a an induction of a vaginal birth for that baby. Break the waters, maybe put up some syntocinon infusion and get that labour up and going.
Yep.
And watch very closely, probably continuous fetal monitoring, and make sure that the baby's coping with the extra forces of labour.
Yeah.
And so it's a big day for the baby being born.
Yeah, we sort of forget about that. It is, they're getting squished and pulled and
exactly.
pushed.
Yeah. And that might be fine. And it might go well and have a vaginal birth, or the baby might start showing signs, in particular on the fetal heart rate trace, that they're not coping with the contractions. Fetal distress picture develops, caesarean section saves the day. That's that's common outcomes.
Yeah.
And then we might have another situation where we just think this baby is a sick baby.
Yes.
It's too small and it's too early.
Yeah.
And there's just about no chance that this baby's going to go well in a vaginal birth.
Yeah.
Especially if it's mum's first time and the labour's expected to take ages. And you might just do a elective caesarean section. Yep. And in cases of very severe growth restriction or very early babies, that's also a less traumatic way for that baby to be born. You can hand a small, relatively delicate baby directly from the uterus straight to the hands of the paediatricians without the rigours of the natural birth process.
I could imagine it would be quite distressing to have a diagnosis of IUGR, but I hope that, just as a recap, that there's some babies that are healthy in the low centiles, and we just need a plan for those that we think we need to keep a close eye on.
Yeah, so trust your team. Once the diagnosis has been made, the management is good.
Yeah.
The improvement that we've got to do is in making the diagnosis in the first place.
Yes.
And if you as the pregnant mother feel there's a problem with the growth of your baby, you may well be correct and speak up.
Yep.
A reassuring ultrasound will be incredibly reassuring for you and your team.
Yes.
And an abnormal ultrasound is the way forward. You'll say, okay, fine, now we've got a problem. How do we fix it?
Now, these are the plans and the protocols, because I can imagine this is something you guys are doing a lot.
Yeah, exactly.
Yeah. Excellent. Well, I hope that that's helpful for all those people that have asked for a podcast on IUGR. I forgot to ask, how common is it, Pat?
Well, it depends on severity and so
Yes.
forth, but at least 3% of babies and maybe as many as 7% of babies, depending on your definition.
Parameters.
Yeah. I think because of the contribution being made in a country like Australia from obesity and diabetes, I think those numbers won't be going down.
No, that's right. Yeah.
There's an important contribution from both those conditions, and the rate of those things is going up.
Yeah. All right. There we go, people. I hope that was good. And if you are so inclined, pop over and give us a 5 stars on our iTunes, or just send us a DM. We love hearing from you, and we hope you have a great week.
Thanks for listening, everybody.
Bye now.